if they don't understand the urgency of changing the way we work and train, that must be interprofessional, they are not socially accountable. It's unethical thus. So the purpose of interprofessional education or interprofessional collaborative practice is driven by the global priority to reach health equity. And this is a beautiful picture. I hope the translator can have the different words. The difference between health equality and equity. Equality is we give everybody the same service. Equity means that the very rich and fortunate doesn't need so much. The person with disability needs much more so that all can have the same outcomes. We are reaching for health equity, not equality. So there's two ways we can reach this according to the Lancet. We have to reform systems for health. And please note, the World Health Organization nowadays don't talk about health systems. They talk about systems for health. If I talk about health systems, you are excluded. The educational psychologist,
Yes.
or educational
Early intervention.
Yes.
Yes.
If I talk about systems for health, you're included. And the other one is to transform our training. So let's look at how must we transform our training. And that will lead us to the ICF. First of all, our approach must be person-centered. Currently, it's nurse-centered or doctor-centered. Okay? The doctor knows all. Even God sometimes reports to the doctor. Okay. We must be person-centered. What does that mean? We need specific competencies to be person-centered. It means, and I hope you can read here, first of all, we must have a bio, psycho, social, spiritual approach instead of a biomedical approach. Okay? Bio, you know what that is?
Yes.
Making a diagnosis, prescribing something.
Biology, yes.
Okay? I treat with chemicals. If in doubt, I cut out. If cut out or medicine doesn't work, it's all in your head, I refer to the psychologist. That's biomedical. Psycho, you know what psychological means, your psychological makeup, what's wrong. So there's a psychologist here. Social, what's your home environment. Spiritual, what is your worldview? What is giving you purpose in life? So that must be my view, how I look at a patient. This is a complex environment if I start looking like this. So it's incorporating the complex interrelatedness. A lot of things are now complex. When it's a biomedical model, it's easy. Symptoms, science, special investigations, diagnosis, treatment. It's linear. If you're a nurse, it's just tick boxes. Nursing is nowadays a profession of tick boxes, ticking the sheet. That's linear. You don't have to think. You only have to memorize. So the complex things that we must incorporate is we must know what are the changes in body function and structure. We must know how is a person functioning and fulfilling a life role. So how are you really functioning in your real life? You had a heart attack? Are you back at work? Are you running marathons again? Or are you puffing back at home and you can't do anything? That's functioning. Fulfilling your life roles. Can the mother breastfeed again, go to the toilet? In disability, you understand what I'm talking about. We must know the barriers and the facilitators of environmental factors that's influencing health. What are the stuff outside of the person that's impacting on their life? As doctors, we don't want to know that, because then we must get involved. It's easier to write a script and to treat and not to ask the other questions. Okay? So that needs to change. We must know what's going on in the person's life. Also the determinants of health, the social determinants of health. And also the personal factors, the psychological factors the formation history of a patient, those things that formed this patient. Those are all the things we must take in consideration if we are really person-centered. Now imagine if we do this, and it sounds impossible, but we'll have, by the end of the day, we'll know we can do it. This will result in holistic care, in shared decision making, where it's everybody together with a patient making the decision, and where we know the person-reported outcomes. So the physiotherapist, what is patient-reported outcomes? Help us with that. You're the
pain and
we'll put on yours.
like a range of motion, pain, disability, like neck pain, disability index, like these outcomes, questionnaires that we use to assist the progress of patient or the
That's
improvement of patient.
This is what the patient report and see as his own outcomes. So usually we only use our own very objective outcomes. I know what's going on, but the patient may experience something totally different, or the child. So it's important to hear what they are saying, and we're getting that information if we're following this model. This will give us a total new vision in research and knowing what's going on, because we'll get person-driven data, not professional-driven data. And that's what's lacking. And we need a total new paradigm to open new paradigms in research if you get person-driven data. What does autistic children really, really experience? Do we write that up in our research? Do we ask them? The other thing that we can do, we can reform systems for health. So what is needed to reform systems for health? It's very small, sorry. We need a community-based focus. We need to move back into communities. We need to break down the silos and the professional tribalism. We need to embrace interprofessional collaborative practice. We must decrease our power relationship. Doctor is not reporting to God. We are all equals in the room. Because we're a team. We are there for the patient. If there's hierarchy, we can't put the patient first. And we must use information technology very clever. And we need this approach if you really want to achieve universal health access, universal health coverage. If we want to reduce institutionalized care, we want to keep people out of hospital. And if we want to move towards preventative care. And ultimately, where things are moving now, as you've heard in the one presentation this morning about the genetics, I didn't understand the half of what he was talking about, but anyway, what I do know is that we can start to predict what will happen with genomics. With epigenetics, we can have a better idea what will happen. With functionomics, what we're talking about now, we know what's the prediction. You have genes, you're living in a specific environment. Functionomics, and we're talking about here when you talk about holistic care, means how can I then effectively prepare you to cope and to live with things that we probably can't change. That's predictive healthcare. Now, we can't do prediction if we don't have big data. We can't have big data if we don't have person-centered data. We can't only rely on the data that we saw this morning. That is skewed. That's biomedical data. So what will patient-driven data help us with? It must help us to reach health equity. Because if we democratize health data so people can say they say, it will help us that we can help people better and we can reach health equity. On our own, as the medical and educational professions, we can't reach health equity if we don't have the full cooperation of the citizenship, of the citizens. So we can do this today with mobile technology. And we're working on that in the WHO. I'm heading up such a project. Which means that within the next 5 to 10 years, persons will be able to capture the information using this model. And we will be able to help to use that data for each person to have an individualized plan. In our pilot study for this project, we've used persons with short stature, 131 of them. Now there's an algorithm. How do you treat all the different problems of people with short stature? There's an algorithm. How do you treat sepsis? There's an algorithm. After the 131 completed the trial run, there were 131 different plans. Totally different plans. 131. They were different.
For each patient has his own plan.
After you've analyzed what are each person's specific needs, if it was just a doctor, I will follow the algorithm. I won't ask certain questions because there's things that I do as a doctor. When you ask the patients in depth, you realize each person is different. Each person is from a different area with different needs, different parents, different work, different emotions. So there were 130 different plans. So where we are moving towards with predictive healthcare is we're moving away from our algorithms that we are love so much that we don't have to think anymore. Moving towards individualized, personalized, person-centered healthcare. And the ICF will help us to go that way. Any questions at this stage? Or comments? Can we move on? We know if you use the ICF and interprofessional collaborative practice, it improves patient outcomes. You don't have to make notes, you can get the presentation.
Really?
Yeah, you can get the presentation, please. You can use it also.
Can you send it for us in email?
I will send it to me, yeah. It's philosophically, it's the right thing to do. Let's take a pediatrician. There's a child with necrotizing enterocolitis or meningitis. You treat the patient with antibiotics. You don't talk to the parents.
No.
You don't share with them. You tell them, well, this child will be disabled and he'll probably never be able to use his left arm. Sorry for you. In 6 months' time, the outcome will be the same. As if I really spent a lot of time with the parents. I prepared the parents. I made sure that he went to the occupational therapist and the physiotherapist. I linked him up to the educational special needs persons. I followed up on them and I remember their name. But in 6 months' time, the kid will probably be the same. But what's the right thing to do? What's the right thing to do? Ethically, what's the right thing to do? That's right. That's right. And then we know interprofessional collaborative practice is a catalyst for change. The moment we start to talk together and have one plan for the patient, things are starting to change. We know improve patient satisfaction. We know when we work together, we move towards a biopsychosocial spiritual approach instead of just a biomedical approach. We know from the bottom we move away from a linear way of looking at things to in the top the complexity and the beauty of life. We know where we are in our different silos and are afraid of the enemy, the other professions. We can actually now cross borders and start to enjoy one another and appreciate one another. We know, like with the Ebola outbreak, it helps us to be resilient because one profession on its own can't deal with it. We know we save 40% of time and 60% of money when we collaborate. Yes. People say, we don't have time for this. we know we save 40% of time because we don't recycle patients over and over and over again. We actually solve problems. We know that we enjoy our job so much more. And it helps us, interprofessional collaboration, to be able to reflect. Because we start to trust one another, we can look at our mistakes. We don't fight, we say, how can we do this better next time? We become critical reflection, and we're not afraid of that. The problem is, healthcare is a team sport, but it's currently being played by individuals. So how can we change this? We've now said, what we've done now is the whole thing about social accountability. Our institutions must become socially accountable, and I just gave you the argument for that. If you must take that back to a faculty or to a department, you don't have a choice. What's ethically the right thing to do? If you are really a leader, if you must really make very, very bold decisions, these are the ones we have to take. The next step is we must embrace the competencies needed, and we must train ourselves and our students in the competencies that's needed for interprofessional education and collaborative practice. What are these competencies? On the one hand, there is the issues relating to client safety and quality. On the other hand, the issues relating to collaborative practice. And in the middle we have the patient, the person, the kid. For client safety, we must be able to communicate effectively interprofessionally. We must be able to function effectively in a team. We must be able to reflect in a proper way, in a mature way. For collaborative practice, we must know what's our various roles. What's the role of a physio, of a nurse, of an educational psychologist? There must be collaborative leadership. Not the doctor that's the king of the group. Yes, when there's an emergency with a meningitis, it's the pediatrician that's obviously at that stage taking the lead. After 3 days, it should be the nurse, because she's there 24 hours of the day, the doctor is there for 5 minutes. So who should be in charge now to really take care of the patient? After 3 weeks to a month, it should be the OT and the physio. So that's collaborative leadership. Whoever is now doing the most is running with a plan. And that's a big shift, but we can't really serve the patient if it's about a leader in the team and it must always be the doctor. Then it's not going to work. Now let me ask you, who of you were trained in these competencies during your studies? Who of you were assessed and had to demonstrate that you can do this before you can qualify? Scary. Sometimes people talk about these things as soft skills. Rubbish. It's hardcore clinical skills. It's the same as listening to a heart or treating a neck spasm. The third thing we need, or the second thing we need to effectively introduce an interprofessional collaborative practice strategy is we must talk the same language. If I talk about the contextual factors of a patient that's impacting on his health, what the special need educators, the psychologist, the social worker, and the doctor understand under contextual factors is 10 different things. If I talk about environmental factors, some people think about global warming. What do we mean? Is there an environment around the child? If I talk about functioning, the physiotherapist and the OT will give you a list of 9 different things that's functioning. As doctor, up to a few years ago, I will say, well, functioning. Can he bath? Can he dress himself? Can he climb the stairs? Can he put on his clothes? Can he bath himself? And what? Quality of life, quality of life. No, we were just blah, 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 blah. Okay, we didn't have a clue. So how can we talk the same language? We need the same language, and that's where the ICF comes in. Who of you are familiar with the ICF? So some of you, if you don't mind, let me just give a recap for everybody on the ICF. So the ICF is the International Classification of Functioning, Disability and Health. I'm just going to stand. This is the framework, the conceptual framework of the ICF. And it actually embraces health in its fullest. And all the things, this is so rich. It's a simple diagram, but it's so, so rich. It can be used on individual level with a kid or a patient. It can be used at institutional level, in your school. The whole Swiss education system runs on ICF. The whole Swedish social welfare system runs on ICF. So if I know, and if I have a profile of all my kids in my school, I will know institutionally where are we good at and where are we failing. Where should we focus our resources more? Where do we have a limit in? Now I can prove I need 2 more physiotherapists instead of just saying I need 2 more physiotherapists. And it can be used at social level to determine grants and to plan your social system. So where do we start? Each patient or kid, we must have a goal how to help that kid to be fully healthy and well. What are our goals? With that specific, sorry if I talk about patients, I'm a doctor, so if I just use the word patients, just replace it with kid or learner, okay? I'm not going to use client because I don't like client, but I know the physios talk about client, so let me just talk about patient or person. Is it okay? Forgive me, please, in advance, forgive me. So, to get to that goal of the specific, or the goals of the patient, we need to know what are the different changes in the body function and structure. Now, for as a doctor, this is what I'm qualified in, to know what's the differences in body function and structure. I must evaluate the mental status of the patient, the sensory functions, the voice and speech, the vascular and circulatory system, the respiratory system, that, and that. And if I'm a physiotherapist, well, musculoskeletal fell out here, sorry. Where's musculoskeletal now?
I don't know.
Okay, musculoskeletal must come in there. Then it's your specific. I mean, voice and speech, we know who's the specialist on that, the speech therapist. Okay. Those in special education, you also work with voice and speech. Then there's functioning. That is the activities, the limitations of activities, the participation and the participation restriction. With activities we mean the things that we do every day. Participation is where we have different life roles. As a father, as a friend, as going to the mosque. I have certain things I participate in, and I go to work. That's participation. I've just mentioned that. So participation and activities are measured like body function and structure. We measure according to the changes that's taking place. There's a change in your heart because you had a heart attack. Okay? So physiologically, we can measure that with an ECG. Anatomically, there's a clot in an artery. Okay? Functioning, we measure in terms of capacity and performance. So let's have a look at this video. I want you to tell me what's the difference, and I will tell you, sorry.
Talking about expectations. Watch.
Ba, ba.
Okay.
Okay. So what's their capacity and what's their performance? The capacity is when there's somebody standing in front, jumping up and down, they can sing. If they go home, do you think they can do it?
I don't know.
Probably not.
Yes.
Let's say probably not. Okay, if he was not standing there, they won't be able to do it. That's performance. Somebody may be able in the rehab center to do something, but if he's living in a shanty town with sand, without the equipment, the performance is very poor. He may have the capacity, but have a poor performance. Okay? So just as quickly, I'm not going to spend much time on this. The different, and this is more for the doctors, not for the physiotherapist, for the rest of us. Okay? What are the different issues if we look at activities and participation? We want to know, can somebody learn and apply knowledge? I tell you to drink your pills, but he forgets about to drink it. Can you apply knowledge? Somebody with a stroke or a kid. Can you perform general tasks and demands, doing things together, organizing things, working with money? Can you communicate, understand, or produce language, or write? Communication. Can you move? Can you care for yourself? Washing yourself, healthcare. Can you do things in house? Cook, clean the house, stuff like that. Make your room, make your bed, put away your toys. Is there interpersonal relationships within the family, intimate relationships, sexual relationships? How are you functioning in that realm? And in your major life roles of education and of working? And how do you participate in your social activities? Now, as a doctor, I was never taught all these things about functioning. And it's so important. Because if I had a heart attack, and after they've gave me my strep to kinase, and they've put in the stent or did the heart what do you call it in English? The bypass surgery. Through all of this, my biggest wish is I want to go back to work. I want to be a father for my kids. I want to run a marathon again. That's the thing in the back of my mind. Functioning is in the back of my mind all the time. Not, doctor, please remove the clot from my second artery to the left. You understand what I'm trying to say? Functioning is so important. And that's where we latch on to make, and if you focus on functioning, then it gives purpose to a person's life, if you need to understand that. Now you can see all these things, all these things interact with one another. It's a complexity. The third thing, or the fourth thing, is what we call the contextual factors. That consists out of personal factors and external factors. Personal factors, stuff inside of me that's impacting and that will impact on the outcome. For example, my age, my gender, my race, my drive, my motivation, my coping skills, my attitude, those are all things in me that will determine the outcome of my cancer. If I don't want to fight and I think I'm going to die and I don't want to live anymore, I probably won't. Or am I a fighter? I'm motivated. I'm not going to lie down. And then there's the environmental factors. So important. So important. And research have shown if we interrogate or assess a patient, if we start with the environmental factors, we get a much better overall history and understanding. Usually we start with the symptoms. If we start with the environmental factors, we know we get 40% better information out of a patient in the end. The first thing we talk about is products and technology. You have medication, you have a walking aid, you have a wheelchair, you have a cell phone, you have a car. The natural environment. I have a house with a toilet, with a bath. Or I'm living in a shack with a toilet half a kilometer away that I have to walk through the sand to go to the toilet. And then there's gangsters on the way and I get raped. I see that every day. Really. Support and relationships. What are the support systems? The family, the friends, the employer. That can be, we measure environmental factors according to barriers or facilitators. So, my angry boss who doesn't want to give me off, that's a barrier. My helpful husband is a facilitator. The attitudes of people, positive or negative. Stigma. People with disability mustn't be seen outside because it will stigmatize the whole family. That's stigma. Services, systems, and policies. How long do they have to wait before they can see you? In my one clinic, I didn't understand why all the quadriplegic patients were late or never pitched, because the appointments for the clinic was 8 o'clock in the morning, which means they had to work at 4 o'clock because it takes 4 hours for a quadriplegic to get right, to do all the stuff they have to do. So they can't be there at 8 o'clock. So we moved it to 12 o'clock. Now we have a full clinic. If we know more about health systems and policies as we evaluate our patients and we record some of these things, we'll have data how the system must change. Otherwise it's just like this. And obviously, if you look at these things, often you ask students, those of you who are at university, to write an ethical case. Or there must be, at each patient, something ethical. And then they say, well, doctor, I can't really think about something. Or they write something absolutely nonsense and irrelevant. If you look at these environmental factors, I want to bet you there's not one of you who won't find an ethical case out of these things. And the patient charter is all environmental factors. And each one of you will have a patient charter or a patient's rights charter. It's all environmental factors, most of them. So just to summarize the ICF, body function and structures measure the changes that there is. Activities and participation, the capacity and the performance. Environmental factors, the barriers and the facilitators. Personal factors, it's either positive or negative. So the ICF is actually the result of this complex interrelationship between a health condition, participation, and contextual factors. It's complexity. You have to think, which is a big hindrance for students because they're not used to that. I was actually reported to our dean by one student of the student council after we've done the ICF. I had a very positive response, but this one student that was on the student council, and he said he has a big problem with Dr. Snyman. He forces us to think. So I say, well, I take this punishment with pride. Okay. It means there's no linear relationship between things. And we need to start thinking critically and complexity. And that's how we cultivate change agents. That's transformative learning. You have to think outside of the box. So let me tell you a story. I love stories. Stories tell things. The story is the story of Stellenbosch University. It's in the southern tip of South Africa near Cape Town. And it's on our rural clinical platform. Now, this is about 5-6 years ago. We've asked our students, when we introduced the ICF and interprofessional education, they went on the medical students on their family medicine rotation. In community health, it's a combined rotation. The physiotherapists went on a community physio rotation. The occupational therapists went on a school rotation where they rotated through the schools, but all on a rural platform. So they lived in the same house, all the students, and then they worked there, and they had the one thing they had to do, they had to together evaluate 2 patients during the month. Obviously they had much more patients, but 2 patients they had to work out by using the ICF. So what happened was that the doctors and nurses and physios and OTs working in those areas who supervised them didn't know a thing about ICF. The physios a little bit, but they didn't use it. So the students now had to really work out a patient, and they were the case managers, and they had to liaise with the physio, the doctor, the dietitian, the nurses, and as they liaised with them to try and figure out what are we going to do, they used the ICF. So this sort of rubbed off. Then at the end of the rotation, we convinced each hospital that instead of that, just the doctor assessing them, okay, now you must present your patient. All the professions sat together. They didn't use this as an exam. Now present your PowerPoint here and present my case. Okay? It was a discussion. Because we've seen through the month what you were doing anyway. And the three of them, the OT, the physio, they presented and discussed their patient. After 3 months, I started to get phone calls from these hospitals. Dr. Snyman, this ICF thing, it's really changing the care in the hospital around. Patients are very unhappy because only a few of them get treated this way and they get better care. The patients are now all demanding to be treated holistically. Please come and train us. So I went. And on a Friday for 2 hours during the journal club or when the hospital got together, I did pretty much this type of training. And I did over 4 months, 3-4 contact sessions. So what happened next? 2 months later, I visited one of the hospitals, and on the overbed trolley, where they put the food on, there was this big A3 paper lying there with the ICF framework on it. And everybody, the nurse, the physio, the OT, the doctor, were making notes on the various places regarding the ICF. And they used this framework to have one plan for a patient. They started to work interprofessionally. Now, what's the difference between interprofessional and multi-professional? Multi means we work in parallel. Passing the buck by referral letter. Scribble a letter. Physio, please. Sore back. It's not my problem anymore. It's now your problem. I'll continue to deal with the fracture. I'll remove the plaster, but, well, you're lucky if I do refer to you. Anyway, be very grateful. So, they started to work together. Now they had this form. 2 years later, the whole province accepted this form as the assessment form for all patients. The discharge form, and I can send you, well, you're actually going to use the form. The form is actually now the official discharge form of a patient. Every patient that's discharged must be discharged using ICF.
From each specialty.
Everywhere, this is the discharge form. It's the referral form as well. Okay. I may not know everything, but you can add to it. So we're working on, it's a working form. So, this is a beautiful story. I'm going to tell you one more story and then we get into our exercise. There were two students placed actually at that place there, Malmesbury. Okay? And they were on call to 4th year students. They were on call the evening, so they worked in outpatients and they helped in the hospital. It's a small hospital. There were one doctor on call and 2 nurses.
Excuse me, it seems that the translator is not translating.
Okay. Somebody just... translator, can you hear us? Oh yeah, would you please move around and just ask him, tell him that something is down or dead? He seems alive.
It's working.
Okay, is it back on? Okay. There were 2 students there. It was a quiet Thursday evening in the hospital, which is unlike, but outpatients was very quiet. The one student was with the doctor in the theatre, and they will be there for quite a while. One patient came into outpatients, and the student saw the patient. There was also a registered nurse there. And it was actually a very simple case. It was a woman with a vaginal discharge. She had a sexually transmitted disease, which is very simple. Triple therapy, antibiotics. So not really a good case to present. Do you agree? I mean, what do you say? You can't say much. It's a woman with an infection, so it's not really one of those patients you want to present to your professor. You would like a complicated patient to make a big impression. So the student was sitting there because they can't give the prescription because the doctor is in theatre. So the student thought, well, let me chat to the patient using the ICF. And he started to use the ICF. And he started to ask about body function and structures. Well, that he sort of sorted out already. Sorry, it was a she. She sorted out already. Then move on to functioning. When she got to interpersonal relationships, the woman wasn't very talkative. She sort of broke eye contact, and the student sensed there's something wrong here, but didn't press too much. She got to environmental factors and asked about support. Where do you live? Now I live at the back of a home in a little Wendy house, a little wooden structure, with my boyfriend and my 6-year-old kid. And she started to cry. When I asked about attitude and the attitude of a boyfriend that she's living with, she said, well, she called the student doctor, but the file you have there is not it's my second file. I have another file that's also here. The student went and fetched the file. It was this thick. Over the past 2 years, every bone in her body was fractured, and she had concussion, and a skull fracture, and a femur fracture, and a forearm fracture. The boyfriend, he assaulted her. Nobody ever did anything about that because, well, we are here to fix the bones, aren't we? We don't ask about anything else.
We usually ask about the result, how she fractured.
That's not, well, I got injured, doctor. Because the doctor, you're not going to share that my boyfriend actually assaulted me and broke my legs and my bones if you know the doctor is not really interested.
But usually we ask the patient, what is the cause? How come?
Even if the patient has told you, you may not have the courtesy to make an implementation regarding this.
Yeah, or many doctors will say, oh,
Intervention, yes.
yeah, many doctors say, oh, well, this bastard. How can he do something like this? And that's about it. Don't involve me. I'm an orthopedic surgeon.
Yes.
Okay? This is something for the social worker, and perhaps tomorrow after the operation I may remember to refer to the social worker, and we don't have one in the hospital, by the way. There's no social worker. So, the student asked, did he rape you? Yes, that's why I'm here. He raped me 2 weeks ago. Well, actually 2 weeks ago she had an abortion. He forced her to have an abortion 2 weeks ago because he raped her. And your 6-year-old girl, yes, he's molesting and raping her too. Where's the girl now? In the shack with him. Okay, so what's our priorities now? Triple therapy, antibiotics. What's your priority now? The young girl. The young girl is my priority, okay? So the first thing is call the police. Did that. The police are out on a farm. There was a murder and they only have one vehicle. They can attend to this tomorrow. Okay, so the police isn't an option. Next. The social services. They phoned the social worker. She's living in a next door town and she didn't answer her cell phone. Next. Yeah, what will you do? You're now sitting there. The first two logical things didn't work, so what's next? Yeah. Sorry?
provide a safe environment for the family to live in. So probably provide a hostel or something safe for both the girl and the mother to stay in.
That's the ideal, but how do I do it now? They phoned the ambulance. The ambulance said, no, this is a social emergency, not a medical emergency. It's not in their scope of practice. There's no telephones there.
You want me to go my way?
Okay, the next thing is she asked the nurse, "Nurse, will you go with me?" We get in a car with the mother. The nurse said, "Well, there must always be a nurse in the hospital. Sorry, I can't leave." What the student then did, the student bribed a porter. You know what the porter is? That's pulling the trolleys in the hospital. Because they're always missing. I'm not sure here. You always struggle to find them. So she bribed him with a can of Coke and tell, "Please come with me and the mother," because she was two girls to go into that. They wanted a man with them. So they went and fetched the kid. The next morning, the student presented this case study because each morning the whole hospital are together to discuss patients. It's a small hospital. The student presented this case according to the ICF. When we came to health, to systems, policies, and services, can you imagine? The system failed the patient because there are rules. And the whole hospital decided, this is not why we are here in the community. We really want to make a change. This won't happen again. And they got together with the police, with socials, everybody. Obviously, in the end, they got the mother to a safe place. Okay, in the safe house. But this was one student who actually used the ICF and changed the whole hospital around. One fourth-year student. So, would you like to take a short, just stretch your legs before we get to the practical exercise?
Yes.
Just stretch your legs. Took a bit longer because I had to speak a bit slower. So let's take a 5-minute break and then we get into a nice practical exercise to practice the ICF. Okay. We're sending around a paper. If you can just write down your name and your email address. I must be able to read the email address, please.
So you send for us
Then I'll send you a link to the presentation. Don't write the email address in Arabic, please. Okay. Thanks for that. I didn't know. Case study in the meantime. Okay? To understand the exercise we're going to do now. Yes. Can you just hand out to those who doesn't have? Okay, so the exercise we are going to do now is an exercise that you can also do in your group with your students. And if you need any of these papers that we are using, you can just email me. I'll anyway put them on a Google Drive, and I will send all of you the link to Google Drive, and you can download whatever you want. Okay. So first of all, just tear off page 1, the written that you get to the form. Just tear it off, that you have 2 different pieces of paper. So if this is the, just tear off this first page. Okay? I'm going to play you the case study. So first of all, what you will do, you can also take out the staples if you want to. You are going to complete page 1 for the case study in a group. So you're going to sit in groups and work in a group. Okay, with different professions in a group. That's why you have stickers. Then, in your group, you will select somebody who will be the patient. So the case study we are going to do will be, unfortunately, I brought along a case study with an adult. I should have brought one with children now that I see it's the group. Okay? But let's work with somebody with Parkinson's disease. So the person we're talking about today is somebody with Parkinson's. So whoever in your group thinks he knows the most about Parkinson's, that person is the patient. Okay? So first of all, I will show you this video. You have the case study in front of you, and you will then complete the information on this ICF framework, the other 3 pages, the 4 pages, the 3 pages. Okay? You will complete the information on here. Okay. Then the second step is, you may want some additional information. So you can ask the patient, or the patient, because not everything is in here. It doesn't say here how this guy is urinating, and we know that people with Parkinson's may have problems with incontinence. So you can ask the patient that, or the patient can share that information. Okay? Or if you think the patient is depressed, you can ask 1 or 2 more questions. The patient can decide however he wants to answer, or she wants to answer. Okay? Then you'll see here on, if you go to page 9, or number 9, okay? You will see there's a section for the changes in body function and structure. You know what that means? And what are the goals for this specific problem? Okay? The same with functioning. What's your goal that you think that you as a group have for this specific item? Okay. The third thing we will do, once we've completed the form, this is your assessment form, we will start linking things with one another. Say, for example, we have a kid with autism. Okay? The kid can't talk. The mother doesn't speak to the kid. And he's not in school, or there's no language teaching. So the one is under functioning, the one is under environmental factors, and the one is body function and structure. So those 3 things are connected to one another. It's 3 different things I have to address this one thing. So we're going to connect. That's why I have this in the end. We are going to connect the various things that belong to each other. So that's the complexity. It's not a linear do this, do this, do this. We're going to cluster things together. Because those things we cluster together, not one of our professions can handle on its own. We need one another to do that, but we need one plan, not 3 plans. Okay. Okay. So, I've said that, and we're going to do that again. I'm going to discuss this later. Okay, lastly, what we're going to do, we're just going to look at how, what we've discussed, how can we improve the health system because of this. So let me show you the case study. So listen carefully. Everything is on this piece of paper also.
This is Peter Jacobson. He is 76 years old and was diagnosed with Parkinson's disease 5 years ago. Since his diagnosis, he has done his best to stay very active so he can maintain his level of function. He meets with some longtime friends several times a week for breakfast and playing cards at the local senior center. However, his condition has gotten worse in the past 6 months. He is more tired these days and has some difficulty getting around. His equilibrium is a little off, and after falling twice in the same week, he has begun using his wife's cane, which embarrasses him. He is having difficulty eating and shuffling cards due to his hand shaking. He has been taking Sinimet for 3 years, which he says has helped tremendously, but now he is noticing even worsening tremors and freezing episodes at the top or bottom of a flight of stairs. He is becoming frustrated with his condition, and his wife thinks he's showing signs of being depressed.
Mary! Mary! I'm back! Mary! Mary! Are you up there?
Hi, sweetheart. Yes, I'm making up the bed. How was breakfast?
Fine, I suppose. I had a few problems.
Listen, I need some help with this comforter. Can you come up and help me?
Let's move. I'm coming.
Dear, are you coming or not?
Mary, can you come down here? I need some help.
Oh, no. Again? Well, you remember what they told you, right? You take 1 foot and move forward. Peter, take 1 foot and move forward.
I'm coming.
Okay, count. 1, 2.
I'm coming.
1, 2. 1, 2. Take 1 leg and move forward, and then your body will remember what to do once you get started.
I'm coming. I'm coming. I'm coming.
Yes. I usually like to read paperbacks.
Well, this was a paperback too. I mean, it's borrowed from some what was very interesting, and that it was a picture of a chess game. Pete,
You okay?
you okay?
I'm okay.
I'll get it for you.
I spoke to you.
There you go.
I gotta go to the bathroom.
Okay. Give you a hand.
I'm all right.
It's not easy. You know, using a car. In a car and going on a trip makes driving a lot easier.
Sure. Keep your mind on the driving and not
Right.
what you're listening to.
Pete's in
He's
bad
having a
shape.
problem.
Well, here comes Pete.
Yeah.
Blast.
Late again.
Sorry, guys. I was held up.
Hope they didn't get too much money. Look, grab a seat.
Give me some cards.
Oh, yeah, we'll do. Oh. Need some help? I guess you made it. There you go. Keep trying. It's your turn, Mama.
Yeah. Oh,
There you
it's
go.
like a good card there.
You're next, Pete.
Yeah, go ahead.
Oop. Get those magnetic cards.
Yeah.
Sorry.
Well, sorry.
Let's see. Oh, this is a good one.
Hey, that looks good too.
It's a good king. You're picking all the cards up.
Yeah. It's your turn, Pete. Good.
Hey, Pete, do you need a break now?
Yeah, I need a break. I need a break from this damn disease.
Okay. What I would like us to do now is we're going to work in groups for the next 20, 30 minutes. Okay? So I think, how many are we? 2, 4, 6, 8, 10, 12. Okay. So I suggest we make 3 groups of, okay? But of different professions. Okay, so I don't want the 4 special needs teachers in one group. You must spread yourself between the groups. Obviously there will be 1, 2 of you in one group. So group 1, let's see who's group 1. Let's quickly, perhaps you can quickly go to your different groups. Okay, you've seen, I've set out chairs there. There's 6 there. You can, there in the back, make a group of 4 there, a group of 4 there with those chairs, and a group of 4 there on the smaller chairs. Okay. So quickly go and sit in your groups. Make sure that you are various professions in a group according to your stickers, and then we can start with the game. Okay. So group 1. Okay, so if you can be 2, 3. That's group 1. They do the environmental factors. You are group 2. You do the functioning. Group 3, you will do the body structure and function. So let me quickly tell you again what you have to do, because as students you probably forgot already. The first thing you have to do is to complete page 1. Then select a patient in your group. Okay, and then you map the information to your sheet. Okay, so those responsible for functioning will go to the functioning page and you'll complete the functioning stuff. If you have any other questions, you can make them up. So you can decide, here's my patient, whatever functioning question you have. You can't remember to drink his pills anymore. It's not in the case study, but you can make it up. Okay? So then for each of the items you have set a goal. Okay, so just do that for now. Then I'll give you the further instructions. Otherwise, okay, so just map your patient to your piece of paper and discuss that in your group. Okay, I want you to do it interprofessionally because you have different aspects that you can think about. Take another 5 minutes? Yes. Okay, then we can finish. I think this is. So, body function and structure. Can you quickly come and present what you wrote?
The first thing was that he has a...
Okay, all of you need to listen now.
Assessing the mental status and the emotional status, and we have assumed that he is having frustration, stress related to inability to perform activities, reluctance to perform these activities. Okay. Okay. So we have suggested an action to make a referral.
Can you use the mic, please?
Okay. So I will repeat again. Okay. First, we have assessed the mental status and his emotional and psychological status. We have assumed that he is having frustration, stress related to inability to perform the activities, and reluctance to perform these activities. And maybe he has a problem in attention span also. So we have suggested a referral to psychologists and guidance to the wife on how to support to better support the patient. And this was the first thing. The other thing.
He has a problem with blood pressure. Okay. We found that he has a problem in blood pressure. So we will reduce the stress exercise. يعني I will not expose him to too much exercise that increase his blood pressure. Second, he has a heartburn with exercise.
So we have
Yes.
suggested to
Manipulate the environment. That we found that his bedroom is upstairs, so I will make it in the base. Yes.
Okay, and also we can give him salt-free food to avoid the increase in the blood pressure. Okay. Another assessment was regarding the drooling and swallowing difficulty. He has recurrent choking. Okay, when he is taking chunks of meat or something like that. So we have suggested a softer diet and referral to a speech therapist for making some drooling exercises to decrease the drooling.
Functioning people? The functioning group? Can you present yours? Perhaps you can sit there also and talk. Oh, you're not. Okay, it's fine.
Do you want to say something?
I want to ask how much time is.
If we move quickly, we can do it in 5 minutes.
Okay. So,
Somebody see my sticky tape?
there's some here.
Okay, for functioning, we said we see that the patient is having a difficulty to get up on the stairs. So we suggest that maybe he using an elevator or transfer to another house. For the handling or carrying baggage or something like that, he can use the trolley, for example. For initiating the movement, we can make an exercise and a relaxation technique, so he can try to initiate the movement without stressful techniques. And for the family, we said or we suggest that it should be the family should be supportive for his condition, especially the wife. That's it.
Good. Environmental factors?
Okay, so regarding the products and technology, we talked about the cane.
Okay. So we were talking about the cane. We weren't sure if it was a facilitator and a barrier, but we could say for environments like the country that he lives in, it should be a barrier because we know that he can have a better quality cane than the one he has. We talked about the stairs, that it's a barrier because he had trouble going up the second level in the house. Feeding equipments, when he was in the cafeteria with his friends, he didn't have the proper utensils. So the action plan would be provide the patient with proper feeding utensils. Regarding the support and relationship, we said that the wife is a barrier because we don't blame her. She might have the action plan could be provide her with education and watcher support, and maybe couple counseling to overcome all of those issues between them. But the way she was dealing with him and talking to him, it was a barrier for him. Friends, we said that it's they were facilitators. Regarding the services, systems, and policies, we were talking about the transportation, that it was a barrier because he depended on walking, going to all of those activities that he wanted to go to, and he didn't have any but he couldn't access buses or car or public transportation. So we said that it's a barrier. Thank you.
And obviously also the OT can, there's no OT here, but the OT can give him a card holder. It's something stupid, the OTs have that. Okay. So, we've run out of time. Sorry, can I quickly explain to you what we do next?
Yes.
Okay. So what we do next, we get to the complexity of things. We can see what you've just said. You've mentioned here the fact that it's difficult to climb stairs, which is related to musculoskeletal improvement. They've said that under mobility.
Excuse me, can you use mic?
The purple line. You can see from the body function and structure, we've talked about musculoskeletal is difficulty to climb stairs. Under functioning, it is mobility. Under systems and technology, it is we must get him, and under and also, which you didn't mention, under services and policies, is there housing available where there's only one floor? Okay, so that's is there a housing policy or something that we don't know if this is a government house, their own house? But those things are all linked to one another. In climbing stairs. So obviously there's a role for the physiotherapist here. There's a role for the social worker. There's a role for the council or whoever is buying the house. Even the bank manager may be involved here. Okay, so we need more than one person to solve the stair problem. It's not just 1, 2, 3, 1, 2, 3. Okay? If we look at the green line, what was the green line? The support and relationships. The wife is a barrier and a facilitator under the support system. The interpersonal relationships is a problem. Also with his friends, they don't really understand. Okay? So on the one hand, he has an attitude problem. On the other hand, they just don't know how to deal with it. So it is, and then you have his demotivation under personal factors. I've just written personal factors there. Demotivated, no sense of living anymore, and he's old. Okay? There's no sense we talk about communication and proper communication and support if we must work with the friends, with a wife, and with him. That's the only way we're going to solve the social problem that we have here, and the social relationship, the participation problem. So it's acting at support systems, interpersonal relationships, that's psychology, and to motivate him, that's also psychology. And social work, or the psychologist with interpersonal skills, or the OT. So you can see how in this process we show each other. Now this is a long way of doing it. As you practice, it's like driving a car. You know, in the beginning, it's so many things that you must do. You can't. Now you get to work and you don't know how you got there. You just did it automatically. So this is a way of usually I do this on flip charts. You know, in every discussion room, there's a flip chart, and we quickly draw the things from different professions. What do you see? They wrote it up themselves. It just happens automatically. In the ward, often this big A3 on an overbed trolley. People write their things and people start to draw lines on it. This is one thing. If it was just the Cinemed, which was a problem, and the dosage is out of date, that's just your problem as a doctor. That's just one dot. There's no line connecting it. Okay? But if it wasn't available in his local pharmacy, that was a health systems problem. Then it was medication, that is a product, linked to a health system problem. Okay? If he forgets to take his medication, that's a applying knowledge thing. That's under functioning. So how can we remember it? Then it's the support system with his wife, with a pharmacy, with a doctor. That's a cluster. That's how we solve that problem. It's not just the script that you write. Okay. So this is what I usually do with practitioners if we discuss a patient. Initially it takes a bit of time, but actually we're solving this guy's problems now. We're ticking one guy, we can tick him off. We're spending a bit of time on him, but we've solved his problems. Okay? And he must take ownership in it too. Good. just lastly, what we usually say in this is, what are the issues that we will do for similar patients in our community? So what were the stuff? Oh my goodness, nobody knew that you can actually have OT card holders. Did you know that the OT has card holders? No, doctors don't know it. Now you know it. Next time, it's easy to remember it. Okay? How can we improve the health system? We don't know if there's also a Parkinson's support group here. Is he part of a Parkinson's support group? We don't know. How can we improve the health system? How can we improve this patient's outcomes even better? We are starting to address his outcomes, I think, quite significantly with the way that we are progressing now. It's not just writing up the Cinemed and referring him to the physiotherapist. We're actually solving some stuff. How can we improve our team? Why did it progress so far before we got to this? In his own silo. Okay. So if you look at the competencies of interprofessional collaborative practice, you can see how many of these competencies did we address or addressed over the past hour and a half. Well, we were sort of very quickly reflecting now. You communicated with one another and hopefully, with time was short, learned something about the other professions, about team functioning, role clarification, who's doing what, collaborative leadership, and conflict resolution. Well, we didn't get to conflict, it seems to me, but often there's conflict, and how do we resolve that? So by using this technique, we practice all these competencies needed for interprofessional collaboration. Can I quickly just get some feedback to close with? I just want to get a sense for myself. What did you learn over the past hour and a half? If you can just quickly share that in the bigger group.
I actually, I had a workshop before regarding the ICF, and I tried to implement it in the place where I work. That is a multidisciplinary team.
Interdisciplinary.
Interdisciplinary. No, it's
interprofessional.
Okay, maybe it's not. It didn't reach to be an interdisciplinary.
It's still a multi.
Yeah, we do the clinic together, but when you go to the planning,
separate planning.
Separate planning, and even sometimes the problem is in the patient himself. He doesn't give you all the information that you would need to make the full plan regarding this. But still, the problem in what I think is it's a very good way to think about the patient, but how to put that in action, especially regarding things that you cannot change by yourself. You need some rules and some work from the government, the social, the community around you, and like this. Yeah. So this might be the burden. Yeah.
The one thing that you must remember, students, if you have students that's rotating through you, they can be the agents of change. Like the story I shared, it was the students who changed the system. They didn't even know that they're changing the system. So you can use them as your agent. Mm-hmm. Anybody else that have learned anything that would like to share that?
Yes, I just would like to say that for me, what I learned from this workshop, for my job is being a biomedical scientist. It actually does not stop being a scientist. It's not just following protocols. I actually can do more, and my priority is to improve the patient's health. So that is my priority. But I didn't really quite understand what I can do. Previously I thought, I could, just doing my task, doing what I'm assigned for this is my job. But particularly this just, it's a teamwork. And if we work together, we will have a better, better outcomes for the patients. So, I really learned quite a lot from this workshop. So thank you.
Thank you so much. Anybody else that would like to share something? Yeah.
For me, as a physiotherapist, we usually look into the patient and looking into the biomedical factor that make his complication or his problem. Actually, my master degree was looking into the psychological aspect, and we found that there is a relation between the patient beliefs and his disability and pain regarding low back pain. And from that time, I was very interested to look into that, or look into the patient holistically. I mean, that's the other factor that makes his problem. Usually the patient come into my clinic and complaining of his pain and his limitation of movement, but it is actually related to psychological problem or environmental problem linked to his work or other factors. But what is I am thinking about when going into the clinic, how to implement like this model and work into the patient. And we in the clinic we receive a referral to physiotherapy. And if I have, or I found that the patient has a psychological problem or environmental factors that makes his problem worsen, how can I solve it, or how can I make changes in his life? This is the problem actually that we have in our health system.
It's a big challenge. Eh?
Yes.
It's everywhere. One of the things that works, and usually the allied health professions are the facilitators there, is to start off with saying, to go to the doctor and give verbal feedback, not just write back. Okay, if it's possible, I just want to give you feedback about this patient, this and this and this and this and this. When you see him again tomorrow, when is your ward round? Can I come on the ward round with you? Just to see this one patient. And you give a little bit of feedback. It's breaking down, it's changing culture slowly. Within 2 years, you can probably get to a stage, can we have a discussion once a week with our difficult cases? So let's take a tea break on a Friday or a Friday morning, 8 o'clock, and we have a discussion about our difficult cases. Now each one just quickly share about the difficult patient. Now you start to have combined plans. So the first thing is to have a relationship with the doctor or with the nurse, to make eye contact. That's important. The second one is to attend ward rounds together. The third is to start just first informal discussions, and later on you can have formal interprofessional ward rounds or case discussions. And that's where you have your combined planning. And the one big thing is to use students, those of you who do have students on the platform. For example, on what we do in our academic hospital is often we have too many students in the hospital. The burden is there, we just have to take in too many students. So I say, okay, this patient will be discharged in 3 days' time approximately. Please go to the home, take a university car and can go and do a home assessment, take an OT with you. So now the medical student, the OT goes to the patient's home with a community care worker. They come back. Or if it is a lady who delivered a baby, where is she going back tomorrow? Come and report back. So they complete the picture. So the students are in the often can be the glue to bring all these links together, because we often don't have the time. In smaller hospitals it's easier. Rural hospitals it's easier because you work together. In bigger hospitals it's more difficult, but often you have students there and they can be your slaves. Okay, thank you so much. Sorry that we went over time.